atrial fibrillation. But anyone would like to start perhaps on rate versus rhythm, drugs for atrial fibrillation? Anyone has any points?
I know Richard has very strong views.
Oh, really? Would you like to?
It's clear that drugs used for rhythm control do not improve prognosis, or all of the drugs that are currently used. It is also clear that catheter ablation is superior to drugs. It's also clear that catheter ablation is superior to drugs for rhythm control. What is not clear yet is whether catheter ablation improves prognosis or is safer than drugs for treatment of rhythm control for atrial fibrillation. I think there's going to be pretty good consensus across all of us about that.
Well, I do agree with you, but the but is more related to the fact that if now you try to implement this statement, which again I fully agree with you. If you go to an aged patient, so the typical female 75 years old, which may have some kind of comorbidity. So would you make the same strong statement also applying to every patient, or how you start to go into the more daily application or implementation of your statement?
Well, I think the statement still holds true that drugs used for rhythm control are not going to improve that patient's prognosis. Mm-hmm. It is also true that if one gives catheter ablation to that patient, it's more likely to be successful than drugs in preventing atrial fibrillation. The real question is that an appropriate therapy for that patient, i.e. how severe are their symptoms and what are the risks of catheter ablation? And at the moment we don't know what the risks of catheter ablation, how they stack up against the risks of remaining in atrial fibrillation in the long term. There's some compelling and intriguing evidence beginning to be accumulated to look at how ablation and how maintenance of sinus rhythm might affect risk, but that is non-randomized data at the moment, and we're still waiting for the randomized data. But the non-randomized data suggests that it will improve prognosis.
I think, Angelo, it's a very important point that you raise, asking who's going to be the optimal candidate for a certain therapeutic strategy in atrial fibrillation. In principle, I agree with everything that Richard has said, that catheter ablation is, if it comes to rhythm control strategies, superior to drugs. And that's true for every age and for almost every patient. But that does not per se imply that catheter ablation is the best therapy for all of these patients. No, we have to very carefully draw the indications in the patients that we want to stay in sinus rhythm. Before we address that point, we have to take a look to alternative treatment strategies such as rate control, because rate control is a valid treatment strategy for the subset of patients in whom there is evidence that restoration and maintenance of sinus rhythm is not the best therapeutic strategy.
Could I maybe skew the argument a slightly different way and say that we mustn't take a unilateral approach to our patients with atrial fibrillation. The decision on how to treat a patient with atrial fibrillation is a combined decision between the patient and the doctor. And while we may have lots of evidence stacked up to say that catheter ablation is better than antiarrhythmic drug therapy, once you start to explain to a patient truthfully what's involved with the catheter ablation, it is an invasive procedure. It is a procedure which, when you look at published data worldwide, not looking at specific labs, but published worldwide data, the complication figure that comes out repeatedly is 4%, 5%, that sort of number. And I appreciate the argument that antiarrhythmic drugs have complications, but in a patient's mind, and certainly in my mind, the complication related to an antiarrhythmic drug is a complication at some stage in the future versus an upfront, front-loaded complication with an invasive procedure, with very dramatic complications at the time of the procedure, potentially. So while I do agree with everything that Richard has said for once, I think it's important to bear in mind that we might say to a patient, the best treatment for you is catheter ablation, and they might say, I don't want that, and that's perfectly reasonable.
You touched on a very important point, that the decision about what treatment to give them is based on symptoms. And because we can't feel the symptoms, you're absolutely right that it's the patient that balances how they feel against the risks of the treatment and decides whether it's worth the risk for them.
So essentially you say that for less symptomatic patients, drug might be a good solution.
I don't think it should be a question of that therapy and this therapy. I think we have an arsenal of therapies that we can use for atrial fibrillation. And certainly as patients get older who undergo ablation, the concomitant use of antiarrhythmic drugs after ablation is higher, and the redo ablation rate is lower, not because the ablations are more successful, but because patients are less inclined perhaps to want a second procedure when they're in their late 70s or 80s. So I think antiarrhythmic drugs most definitely have a place to play in the management of atrial fibrillation, be it for rate or rhythm control. But I think we shouldn't dichotomize and say antiarrhythmic drugs really bad, ablation really good. I think both have their place in the management of patients with AF.
So now if you have to make the choice, I mean, we have been 30, 40 years of drugs, essentially. So which would be your most favorite one? So which is the one that you like to
My
start
favorite drug?
Yeah, I mean, well, I think everyone is like a cooking recipe. So we like to have a chef likes to start first with one rather than the other one, or a list has more experience, because it's also a matter of experience and weighting the benefit, the efficacy, the potential again side effect that you can create. So which is your favorite one?
Well, I am fairly guideline informed when it comes to using drugs for atrial fibrillation. So my first line drug in a young patient with paroxysmal atrial fibrillation would be flecainide, provided that they have a structurally normal heart. If they have any suggestion of left ventricular hypertrophy or structural abnormality, I would use sotalol.
That's in combination with a rate controlling
With a rate controlling drug, yeah.
Because that's important for
That is an important point. And propafenone would be my third line drug to use for patients with paroxysmal atrial fibrillation. Often I wouldn't go to 3 drugs, because a patient after trying one would say, I don't like taking drugs, or it didn't work, let's try one more, I've tried 2, I want something more done than this. But I go through that process rather than offer first line ablation for atrial fibrillation. I prefer a patient to try what is, in my mind, a less invasive option, which can potentially offer them information up front to say, yes, that works, and no, that doesn't work. And then when it comes to making a decision about ablation, they're the ones making that decision, saying, I've tried this option, it hasn't really worked, I want this option, rather than going first line to an ablation where there is a possibility of complication, and should a complication arise, that patient will be left thinking, well, why didn't I try that option first?
But can I just ask, because I mean, one of the things that I find the biggest error is not the decision about what rhythm control drug to use, but rhythm versus rate control. And so often you see people getting cardioverted who have asymptomatic AF when there's absolutely no evidence that it's going to do them any good at all. And I think there's more errors made in making the decision to go for rhythm control when patients have no symptoms and no evidence that it's going to help them, than actually what therapy you're going to use when you decide on rhythm control. Is that fair?
I mean, there is an approach that I often take is you have a patient present to you with asymptomatic atrial fibrillation, and sometimes they don't even know how long they've been in atrial fibrillation for, and I will discuss the options with them and then undertake a cardioversion with a rhythm control drug, because I want to see whether they actually notice a difference in sinus rhythm. So we're using cardioversion as an option to justify any further therapy. That's the only time now.
No, I think that's and I do that very often.
Yeah.
But then you're revealing that they really are symptomatic rather than
But what we are missing is still proof that catheter ablation not only relieves symptoms, but also improves prognosis. If we have this data, we can apply this strategy even to patient who is minimally symptomatic or asymptomatic, more or less, because then we can tell them that this is a strategy that can improve your prognosis. But at this stage, we only know that catheter ablation is good to relieve symptoms because it is more efficacious than drugs to do this job.
Do you think the data that is in the literature at the moment is useful at all, or is it something you would...
It's all indirect evidence, so we need data from a real big randomized multi-center trial, I think, in this respect.
I mean, at the end of the day, AF is a chronic disease. We pick it up early, but there's a progressive process occurring in the cardiovascular system, which is and obviously in the substrate in the atrium. And at the end of the day, any good randomized controlled trial is only proves benefit when every patient, if you're looking at mortality, has died in the trial. So you absolutely know the gain that's been achieved. So you need those curves to come together at the end. And if you're talking about an ACE inhibitor trial for heart failure, you may have to wait 15 years to know that. Mm-hmm. So assessing prognosis with AF is a major challenge, because you literally, to really know, you have to conduct trials over 10, 15 years when those curves finally converge. So I think it's going to be quite a long time before, even if we do a randomized control trial, we're only going to have evidence for 1 year, 2 year follow-up in terms of prognosis. But at least that's a step in the right direction.
If I may just continue, I'm maybe the extreme here, and I'm very pessimistic that any rhythm control therapy, whether it be drugs or ablation, will affect prognosis. I'm very pessimistic. Maybe we're just starting the battle too late. And I still believe in drugs, but probably the best drug would be a Dorian Gray pill, the one that keeps us young. And then probably we will have a solution for AF. I think really it's a marker of a progression that our heart is showing, and that maybe we cannot do that much once that marker comes up. And one of the very striking arguments in that respect, I think, is the AF-CHF trial, where a very thorough time-dependent analysis has shown that although rhythm control strategy was able to keep many more patients in sinus rhythm, it did not impact at all on mortality, on cardiovascular mortality, or on congestive heart failure development, although these patients had this systolic dysfunction. So I must say I'm rather pessimistic. At the other hand, we now have trials that try to explore that. We have the EAST trial in Europe, we have Cabana in the United States, that really are designed to look at long-term outcome on heart endpoints, endpoints that really matter, like stroke, heart failure, mortality. If they show any benefit, then I will really be a convicted one, because I'm very critical. So I really think we have to wait for these studies.
Yeah, but I mean, ultimately, in this intermediate stage, probably the best we can hope for is we can delay the onset of heart failure, reduce the risk of stroke for the first 3 or 4 years after the procedure.
Even that we don't know. Because
well, no, but I think that's the best we can hope for at the moment.
Right, but even in AF-CHF, we kept them in sinus rhythm, and the development of heart failure was exactly the same.
Yeah. I wouldn't be that pessimistic, Hein. I mean, it's true that the AF-CHF trial showed disappointing results, so to speak. But it was a drug trial. It was a drug trial, and the theory that what you gain with rhythm control, you lose as side effects of the drugs, is at least a valid one. So I think in the field of catheter ablation, we have to at least be open that the story could be rewritten. If we look to the field of heart failure and atrial fibrillation, focus on catheter ablation, there are multiple studies indicating that you can achieve a significant increase in ejection fraction by effective non-pharmacologic restoration of sinus rhythm. And then it becomes common sense. When you improve ejection fraction, it's very likely that you have a positive impact on heart outcome parameters such as heart failure, stroke, sudden cardiac death, and death. So I'm with you. I think it's kind of difficult to show beneficial effects on heart outcome parameters in patients with paroxysmal atrial fibrillation, preserved left ventricular function. But when it comes to advanced stages of the disease, at least the potential is there, so to speak, that we can do more for the patients.
I mean, I think it's a fascinating area, because until now we have ignored the issue of AF, its association with Alzheimer's, its association with dementia, its association with stroke, because there's nothing we've been able to do about it. Right. But we clearly know that there is an association. The question is, can we break that association?
Key point. Well, one question I have, I mean, because more and more we have really very powerful way of detecting early on paroxysmal AF. I mean, I'm thinking about pacemakers, ICDs, CRTs, so devices in general, who really have memories, so have really a good way of detecting early onset of AF. So what you do in your patients? I mean, are you proactively trying to keep those patients in sinus, and you do ablation. So Richard.
Well, if they're asymptomatic, I think the thing that these devices have really given us is the opportunity to identify AF before they have a stroke and to give them appropriate stroke prevention. So remote follow-up now gives us alerts the minute they have their episodes of AF. The challenge we have is interpreting those data because, of course, all of the stroke prevention studies have been based on patients who have quite a lot of AF. Does stroke prevention work for someone that's had a minute of AF on a device who has a high risk of stroke, where you can actually really clearly clarify how much AF they have? I don't know.
Well, because I'm thinking about all the old studies done in pacemaker patients, where again the technology has significantly changed. Now you can really have high reliable detection algorithm. You can really see in the memory of a device early on, and you can see how many hours. They say you have also remote monitoring. Now the question is, should we redo all the old studies when we have done all the pacemaker story? Because what is consistent is the fact that pacemakers have not been able to reduce essentially the stroke part. Because we had back drugs, we have not been able to have good device memories or good device algorithm, which really, by detecting early on and starting the appropriate treatment, you can really avoid the stroke or the cardiovascular event, which stroke is a major component. I don't know what is your view on that.
I agree. I mean, I think the question is how much AF is dangerous and how early do you need to treat it. And I agree that those would be fascinating studies.
But again, it shows that the only drugs that have made impact on the prognosis of AF patients are non-rhythm drugs. Mm-hmm. It's the oral anticoagulation drugs. And there the discussion now is, okay, from what level of AF is that risk high enough to say, okay, anticoagulation will have a positive impact. But that for me is more like a thresholding question rather than a conceptual question. But conceptually, coming back to the drug treatment, I think we should maybe look more into other avenues on reducing the cardiovascular risk overall of AF patients. And we have been disappointed with ACE inhibitors and ARBs in the sense that they do not prevent recurrences of AF, but maybe they prolong life of AF patients. That we haven't explored yet. So maybe other interventions, if you see an AF patient, should be able to impact on their prognosis, not just the rhythm strategy itself. And if rhythm strategy would also do something positive in prognosis, I really would be delighted. I just want to raise a little bit of cautionary note in this panel.
Can I ask, because I mean, it's a question I'm often asked by people, asymptomatic AF, at what point do you decide to anticoagulate them? Can I ask the panel, how much AF would you start with someone with a high risk of stroke, a high CHA2DS2-VASc score of 2 or more? How much AF do you need to see on a device before you then start anticoagulating?
Well, in my opinion, not very much. I think a few minutes is more than enough. A few minutes is more than enough.
Yes. Well, remember that device patients are a very special population and a very tiny fraction of the population of patients with AF that we treat. So I think that any patient that we see where they even have an ECG taken ever of AF or a 24-hour tape that's ever shown an episode of AF, we can assume that that is the tip of the tip of the tip of the iceberg, and that you stroke stratify them and they get anticoagulation. If
you see these patients today, do you put them on warfarin or do you go for NOACs, for the novel oral anticoagulation drugs?
Well, it depends if you're in Europe or in Britain. There's nice guidance.
Let's not discuss the price here, just availability.
Yes. How would you do that clinically? I mean, it's an open question in Germany as well. How to do it?
In terms of how you start anticoagulation, or
you have a patient that you have to start oral anticoagulation. Let's say 65-year-old retired teacher has a documentation of paroxysmal atrial fibrillation, has a CHA2DS2-VASc score of 4. Warfarin, aspirin, novel oral anticoagulation combinations. What would be your approach?
I mean, I think if someone's got a CHA2DS2-VASc score that high, I would initially start with warfarin, because I think the evidence base for warfarin is more robust, and also the patients have been treated in these factor 10A trials and so on, dabigatran as well, have not been as high risk as CHA2DS2-VASc score of 4 or above. So I would still go for the larger evidence base, provided one can get rigorous INR control. Now, if there are issues with INR control or intolerance of the warfarin with a particular patient, perhaps he goes water skiing every week or skydiving, and then maybe there are issues with anticoagulations overall. But essentially, I would start with warfarin and then think about the other agent if there are issues with control.
Can I just say that if you damage yourself skydiving, I don't think anticoagulation is going to make any difference.
That's probably wrong. I mean, I think the harder question actually is the CHA2DS2-VASc. If you have a CHA2DS2-VASc patient, say with CHA2DS2-VASc of 1, and they have a minute of AF on a Holter.
It's different. It's a different decision making clinically.
I have a different opinion. I think the different trials with the newer oral anticoagulant drugs have shown a very steady benefit compared to vitamin K antagonists, irrespective of the CHA2DS2 class. So I don't think that a higher CHA2DS2 score would be a reason for me not to start with a newer oral anticoagulant drug. At the other side, the lower risk patients, also there, definitely the benefit of the newer anticoagulants is preserved in the sense of a reduced reduction of major bleeding and especially intracranial bleeding. So I don't see a reason to diversify the indication for a newer drug versus vitamin K antagonist based on the CHA2DS2 score. Where you could diversify, I think, is on the other drugs they are taking, because we tend to think that only vitamin K antagonists have drug-drug interactions, but there will also be drug-drug interactions, and especially with antiarrhythmic and rate control drugs, with the newer anticoagulants. And of course, some patients are excluded by nature of comorbidity. If they have an artificial valve, if they have very depressed renal function, there's not a very hard data set that it's safe in those patients. But overall, I would rather jump onto a newer drug.
But Hein, if you look at the benefits from these newer anticoagulants in the trials, they're actually given to them by geographical regions where time in therapeutic range was very poor.
Yes.
Yeah. And if you just look at the data from Europe and the US, actually there is no advantage to these drugs over warfarin because their time in the therapeutic range was very high. So that may not translate to our practice in Europe.
Well, I'm not so sure. I think we still overestimate how well we do concerning INR control. If you get 70% in an individual patient, you're already very well performing, but 70% means that 30% of the time you're or too low or too high, with the risks at either side of the curve. So I'm not so sure that stable INR per se is for me a reason. Moreover, you never know when you have a new patient to start, and that was the question Gert raised. You will not know whether that patient will have a stable INR. So maybe that's still an issue for patients now on vitamin K antagonists, and the question to switch. And there, of course, we can be a little bit more take an expecting or an expectation type of approach. But for the new patients, I do not see many reasons not to go for the newer oral anticoagulant.
There is one more aspect that is
the last point.
Okay, that is not discussed often, and that's compliance of the patient. So if I have patient on a stable warfarin with good INRs, I know that he's taking medication, he's motivated to come for checkups. But if you give patient drug and tell him, well, you don't need to come for some control of this treatment, you are not sure if the patient is taking drugs. So this is another aspect we have to emphasize.
That's a very good point, and that brings us back to the beginning of but it brings us back to the very beginning of our discussions. I think that the newer oral anticoagulants, they may not need INR checks, but I think the patient needs still checks, and we will still use our anticoagulation clinics now as a sort of arrhythmia clinics, and the patient can come back every 3 months to check the compliance, to educate about compliance, but also taking the opportunity to look at all the risk factors that are present in this AF patient and to address them. And so I think it would be a shame thinking that going into the newer drugs would mean we don't have to follow up these patients anymore. AF patients are very high-risk patients, cardiovascularly spoken, and so we have to follow them up, but we can save them the blood sampling, and for them at least that is already a big benefit, I think.